and welcome to our 38th webinar. I'm Neeti Daftari here on behalf of the Circle of Cleft Professionals. Today's webinar is on cleft orthodontics with Dr. Chloe Rowland, who will take us through a discussion on how best to optimize orthodontic care in low and middle income country contexts. We will be having simultaneous interpretation in Spanish for the entire duration of this webinar, for which we have Ben and Eva joining us from Chile. At the bottom of your screen, you will see an interpretation button. If you would like to hear the rest of this webinar in Spanish, please click on that button and select Spanish. If you would like to continue in English, we recommend that you select English to enable Spanish to English translation that could happen during the discussion. Here are some webinar participation tips. If your bandwidth allows, please keep your video on. Use chat to introduce yourself to the group and tell us where you're from. Feel free to type in your questions or comments or Zoom reactions, the reactions button at any point during the presentation or discussion. Please keep yourself muted during the presentation. And if you like to speak during the discussion, you can get our attention by using the raise hand feature within the reactions button on Zoom. Here's the agenda for our hour-long webinar today. We will begin with a quick COCP update, followed by a presentation by Dr. Chloe Rowland for the first half hour. This will then be followed by questions and discussion for the remaining half hour. We have three core objectives at the COCP. Our aim is to facilitate networking and collaboration amongst cleft professionals, to communicate the impact and learning that's happening within cleft care, and to support the growth of local teams in implementing comprehensive care. Our members are spread across the globe. We are now a network of over 750 cleft professionals from over 80 countries and multiple cleft specialties. As you can see here, the COCP represents cleft professionals from a wide range of specialties within cleft care, which includes surgeons and speech therapists who make up half of the COCP, but also social workers, psychologists, nutritionists, researchers, nurses, dentists, orthodontics, and so on.
And orthodontics, right? We just pause there for a second, the mighty 10%. So welcome, especially to our orthodontic colleagues today, that you're in for a treat.
So all of the specialties who make up a cleft care team, this is what the COCP membership is about. We would like to thank these 11 international charity organizations who have come together to make the COCP and all of its activities possible. I now call upon my co-host, Hugh Brewster, to introduce our topic and presenter for today.
Thanks, Neeti. Welcome, everybody. Glad you're here. This is a really exciting topic. Again, my name's Hugh Brewster in Toronto, here on behalf of the Circle of Cleft Professionals. Really delighted to put a spotlight on one of the elements of comprehensive cleft care we haven't talked about enough recently, and that's cleft orthodontics. And I think this particular topic, burden of care, is something that will be of interest no matter what part of the team that you are representing. And so I think often we have partners talk to us about the cost of orthodontics, and that's more meaning, oh, how do we get funding for this? It's a long-term treatment. The costs can be high. But Dr. Chloe Rowland today is focusing more on the cost to the patient. What is that burden of care? If we're offering this kind of service, how do we move forward in a way that facilitates it, makes it accessible for patients and parents, especially from low-income situations, and allow them to complete that treatment? So Dr. Chloe is going to be asking some really interesting questions today. Are all phases of the treatment necessary? What are the objectives we should be seeking, especially in a low and middle income country context? So I'm delighted to have Dr. Chloe Rowland today, who grew up in a Franco-Nigerian household and is now working with the Cambridge University Hospitals and private practice in the UK. She's been connected with Cleft Charity in the UK. And it has some good partnerships there in terms of understanding how that orthodontic care looks for cleft patients, especially in low and middle income country contexts as well. So I'm not going to say any more. I'm going to pass it over. We'll let Dr. Chloe share her slides, and I'm really looking forward to the discussion. Along the way, as always, please feel free to type in comments or questions. We'll note those and be able to circle back to have a rich discussion for the last half hour of our time together today. Dr. Chloe, this is amazing. You're set. It's all ready. Please take it away.
Thank you very much, Hugh. Good. So I think For me, it's particularly important as an orthodontist to think about the amount of effort that families and patients are putting in to be able to complete the treatment plans that we propose. So a lot of the time we know that cleft patients tend to go through much lengthier processes than non-cleft patients. And some of the complaints that I get from my patients even is that they get quite tired in terms of coming in. It takes time away from school, it takes time away from work. And everyone is quite hungry for options in terms of how to reduce their footprint on clinic. So I guess the question that I'm trying to ask us today is, can we reduce the impact of orthodontic treatment, the burden of care on patients and their families, while still maintaining excellent orthodontic outcomes, which we're all trying to achieve? And I'd like to thank a colleague who's not here today, but Dr. Mahfouz Ghani, who I worked with in Bangladesh. He works for the cleft team in Dhaka, and I've used some of his clinical cases as well as mine to illustrate some of our talk today. Okay, so today what we'll be really aiming to do throughout our session is going to be initially defining burden of care, and then more specifically talk about how it affects our orthodontic patients. Run through some of various orthodontic treatments, which are options in cleft. And while every single center and every unit works very differently, it's just really an overview of the types of interventions that we can think about for cleft patients. We'll go through some of the literature that's been published about orthodontic burden of care, and then we'll try and think about different ways in which we can all think about reducing that impact on patients. So burden of care, I think the kind of bog standard definition talks about the physical, emotional, social, and financial problems that can be experienced by family and caregivers. And that's not specifically for orthodontics. That can apply so much to other areas of cleft. A definition that I prefer is adapted from a paper that I found in the Indian Journal of Plastic Surgery. And it's talking about the balance of how much patients and families commit their time, compromise their quality of life to be able to undergo the treatment which we propose. And so really that means for parents, potentially time away from work, time away from school, as a lot of those patients that we treat are school age. The cost of treatment, while I'm in a situation where the majority of treatment is taken care of by the government through the National Health Service, lots of other countries are in very different situations and have to rely on external funding or even private funding as well. There's the cost of travel, because they might not be able to access care everywhere. There's discomfort. As much as all orthodontists aim to be lovely, we know that orthodontic treatment can be uncomfortable. And then there's the fact that while you're in treatment, you're at increased risk of things like decay and gum disease. And we also have to think about what is the long-term burden of maintenance that we're imposing on those patients through all this treatment. So just as a reminder, there are quite a few episodes in which an orthodontist can get involved for patients. So as early as newborns for pre-surgical orthopedics, to facilitate bone grafting, growth modification, so from ages 8 and above, upper arch alignment in particular while mandibular growth is still happening. You can think about the bog standard orthodontic treatment that you think of, orthodontic camouflage or alignment. And then later on, when skeletal maturity is achieved, when patients tend to be around the age of 18 onwards, you start thinking about jaw surgery, particularly if there's been adverse skeletal growth. The last type of step that you can think of is there are some patients who present having had a lot of treatment and who present years later, possibly in adulthood, who would like some of the relapse that they've had from the treatment they've experienced to be addressed. So this is a treatment that I don't personally participate in the center that I work in, but pre-surgical orthopedics can be quite popular in some centers. And the aim of it really is to improve the position of the cleft segments prior to the primary lip repair. And it can need some really good results, but it requires quite a lot of expertise in terms of how to make the appliances and quite a lot of commitment in terms of time from the families, particularly when they might be worried about other things in terms of the development and growth of their child at that stage. Another stage that we'll get involved in, usually depending on the countries, when some of the permanent teeth start to erupt, so age 6 onwards, we think about creating a little bit of a better site for the surgeon for bone grafting to allow the adult teeth to grow in a better environment. And so typically that can be done with removable appliances, such as those depicted here, or with some fixed appliances. I'd say the big disadvantage for me is that once I put one of these fixed appliances, which are called here a trihelix, I then will have to change it to another appliance to allow the surgeon to access the surgical site. So you can start thinking about how all of that takes time, it requires more resources, and means more visits for the patients. So this is an example of a case treated by Dr. Ghani, just in preparation for bone grafting. Something that is quite popular, I think, overall, is thinking about how to address some of the growth issues that we see in our cleft lip and palate patients, where the maxilla has not come forward as much as we'd want to. So partly through effects of scarring and partly just to do with the primary deformity. And so it sometimes becomes a good idea to think about growth modification, and that is usually done with external anchorage, or sometimes thinking about kind of internal screws. But the idea is that quite a heavy force traction is applied onto the upper jaw to be able to improve the position of the jaw. For these types of appliances, if I were to use them, I'd ask the patient to wear them for at least 12 to 14 hours a day to be able to get a very good result. I guess one thing which has to happen is to think about how to maintain that in the future while the patient keeps growing. So orthodontic alignment is probably what you think of when you think about orthodontics in general. For our cleft patients, it can take a very long time because they're more likely to have missing teeth, teeth that are ectopic that come through in the wrong position, crowding, and quite a lot of work. So, but those are the typical things that we do as an orthodontist. And then usually what we think of as the last phase for patients where the skeletal 3 pattern or growth hasn't quite happened in the way that we'd want, we consider jaw surgery, so orthognathic surgery. So this is an example where biomaxillary surgery has allowed this patient to have a slightly better facial appearance and facial profile, as well as a better occlusion. So now that we know some of the stages that make up some of the orthodontics that we all do across the world, we can look at some of the studies that have looked at the burden of care of orthodontics for these patients in particular. So if we look at a Brazilian study that was published in 2018, they looked at 100 unilateral cleft lip and palate patients who completed orthodontics there. And they looked at the burden of care, specifically the length of the orthodontic treatment, the number of visits, the distance traveled for the families, number of appliances, number of surgical procedures that were useful for the orthodontic specifically. So on average, for those 100 patients, the duration of orthodontics was 11 years. Or 11.5 years. Over that period of time, patients tended to attend about 61 appointments. They had about 10 appliances on average and 6 surgical procedures. And so that meant that for those families coming from lots of different areas, they would have had to travel about 630 kilometers every visit to see the orthodontist. Which is quite a distance, and that kind of accumulated to 38,000 or 39,000 kilometers over the treatment. So they also noted that unfortunately those patients that had worse growth, the kind of Gozlon 4s and 5s, the more class 3 patients tended to have longer treatment and worse outcomes. Now, if we look at a very similar study that was undertaken in Poland, they looked at a slightly smaller population and a mixed population. They had patients with unilateral and bilateral cleft lip and palates, and the duration of orthodontics was vaguely similar. They tended to have patients in treatment from the age of 8 to 18 in a fairly continuous manner, with a similar number of appointments to the Brazilian team, and a high distance traveled. Here, obviously, being a smaller country, the distances weren't quite as high. So on average, about 56 kilometers for the bilateral cleft lip and palate patients for every visit, and 87 kilometers for the unilateral patients for every visit. So they noted that the treatment was longer for the patients whose clefts were bilateral, and there seemed to be a greater travel distance for the unilateral patients. So this is a project that I was involved in last year. So we looked in the UK and Ireland at 3 hospitals in England, Scotland and Ireland, and we looked at actually a variety of clefts, so cleft palates as well. And over the 65 patients, we tried to identify how long the orthodontics had lasted, what the number of visits were, and try to have a measure of how successful treatment was by looking at the PAR score. So our treatment time was considerably shorter as a median, so around 3 years, but obviously that includes some of the less complex patients. But the range was quite extreme, so as short as 13 months and as long as 11 years. A number of visits is about 20 visits over their lifetime, and then we try to identify what phases of treatment took the longest. And it seemed to be that orthodontic treatment or orthodontic preparation tended to take the longest, orthodontic treatment and fixed appliances as well, whereas some of the shorter phases were pre-surgical orthopedics right at the start of life. So this is that displayed again in a graph. What was, I think, particularly interesting in that particular study, looking at those 3 hospitals, was the shortest treatment time was displayed by the team in Scotland, who actually focused a lot of their efforts on treating the unilateral cleft lip and palates only. And one of the reasons why their treatment times were shorter was because they delayed a lot of their treatment, and they were aware that because the distances in Scotland are a lot wider than, let's say, the hospital in London, they would try and maximize the effort in that short intervention. And then lastly, we'll look at the Euroclef studies, which was a multi-center study looking at several Northern European centers. And so they looked at unilateral cleft lip and palate patients and tried to determine overall the number of visits, satisfaction of parents and patients, as well as some orthodontic outcomes and dental arch relationships. So again, we had a fairly high number of visits over the treatment period, but a very high satisfaction of patients and parents overall. One thing they found is that in 2 of the centres that had a lot of very early interventions very early on, they had an incredibly high number of visits compared to the other centres, but they didn't particularly have better outcomes than the others. So that leads us to think, how can we minimise some of the burden to the patients and families? How can we reduce the number of interventions? How can we reduce the length of treatment from 10 years in those really important years of life? Is it through changing the types of appliances that we use? So let's start first with the number of interventions. I guess one of the big positives of reducing the number of interventions is reducing the risks of caries, reducing fatigue in terms of treatment. I find that patients who've been treated for a very long time, in my hands at least, are much less likely to complete their treatment to a satisfactory degree. But also, if we reduce the number of interventions, we think about reducing the cost of treatment, whoever the treatment is paid by. So how do we do that? I think it varies amongst your centres, but we have to look at the type of treatment that has an evidence base behind it, that has a good track record, and that the orthodontists that we have locally are very skilled at undertaking. And if we can, avoid any clinically unnecessary or multi-phase treatment or treatment over a very long period of time. I found that this paper in the India Journal of Plastic Surgery was really useful. It looked not only at the orthodontic burden of care, but the general burden of care for cleft patients. And it gave an ideal protocol for this team anyway, looking at the types of interventions that were absolutely necessary, those that were unnecessary, and the type of burden that would be imposed on the patients if they were undertaken. So reducing the length of treatment will tend to yield better outcomes in terms of reducing adverse effects, such as really severe root resorption. If you can think about having braces on for that period of time, you're much more likely to have caries, gingivitis, root resorption. Again, improving compliance overall. And how do we do that really? I think in my hands, I think about not intervening as early as I would have before. So maybe delaying treatment until the permanent dentition if possible, unless there needs to be some amount of interceptor treatment. And I've started to think about different appliances that I can maybe try to use, which would require fewer visits and maybe less effort in terms of lab burden. So we all know that fixed appliances is really the mainstay of orthodontics, and they require regular adjustments, but you can have really horrendous effects with poor oral hygiene. So sometimes there'll be alternatives that I can use, for example, for bone grafting preparation, are a removable quad helix, because it means that it can be removed intraoperatively without changing the appliance itself, and the surgeon can have access to the surgical site unhindered. And maybe some teams might be thinking about things like aligners, because those can be monitored to a certain degree remotely if a patient is compliant, and that might avoid some of the excessive visits. While it's not really used routinely in cleft teams, it is used quite successfully for non-cleft populations. And so what are the other things that as a centre and as a team, other than the orthodontist, that we can think to minimise this burden? So one of the first things is to think about whether the care that we provide is centralised to a centre, whether it's local. I think centralised care is wonderful because it provides centre of excellence. You end up with more skilled clinicians that work with other with a multidisciplinary team. But it does mean that for some patients, these services will be harder to access. So when centralised services are not possible or are quite difficult, could we think about disseminating expertise? So either travelling out to more remote regions to be able to offer care on a fortnightly basis or from time to time, or could we think for more simple plans of having supervised care with other team members or shared care plans? So at the moment, that's what I do for some of my patients that have to travel 2 hours to come to me. I will choose an orthodontist in a hospital closer to home, and we will both agree to a treatment plan and we'll keep in regular contact to see how treatment is progressing. So another important thing is to discuss the protocols with your team. So some of the orthodontics can be driven by surgical need, and it's important that we have a really good idea overall as a team of what we're trying to achieve. So adhering to a protocol means that you're able to look at your outcomes a little bit more transparently. It reduces differences between patients, and it avoids excessively long plans without real direction. So in determining a protocol, what you want to do is look at the most crucial stages of what you're trying to achieve with orthodontics. Obviously, we've talked about this. Scrutinizing outcomes is really important for each centre so that you can see what works and what doesn't in your hands, what is successful and what relapses. And that ensures that high standards are maintained throughout. So one way of doing that is pooling data, maybe with a neighbouring centre or a country that has a very similar setup to yours, by seeking feedback from families to see what has worked and what hasn't, if there are particular appliances that people don't seem to get on with, and very importantly, recording any adverse outcomes. Overall, I think the most important in whatever decision I make is that I involve my patient in how we devise a treatment plan. I need to make sure that at the end of the treatment, at the end of the 3 years or 10 years, my patient and my parents are very happy with what we've achieved. And that usually means that they'll be adhering to any instructions a lot better. So I usually do that by discussing goals from the outset and making sure that consent is informed. So overall for me, in terms of reducing the burden of care for my patients, what I don't do in my protocol, at least in my unit, is I don't do pre-surgical orthopedics. And obviously I haven't done that single-handedly. It's been obviously agreed by the surgeons, but they seem to be happy enough to do those primary repairs without the pre-surgical orthopedics, which can be quite time intensive. We've also moved away as a unit from using growth modification in particular, because we've noticed that actually it doesn't seem to change some of the outcomes later on in terms of the automatic treatment, at least in our hands. It seems to be also, if you look up the Miazzini publication for 2013, they seem to say the same thing, that those really severe patients very early on have no real advantage if you do quite a lot of intervention very early. And in terms of what's reducing in my practice, I think I do a little bit less arch preparation before bone grafting. I think if access is needed, I will try and move teeth rather than move arches completely, because I know that I will have to repeat some of that work later on when it comes to the orthodontic alignment. And when it comes to orthognathic treatment, it's not that suddenly all of my patients are class 1 and perfect and have perfect growth outcomes. But I think that rather than prescribing a treatment like orthognathic treatment, I try to listen to my patients in terms of what they're trying to achieve and try and see if orthognathic treatment truly is what's best for them. So hopefully through our chat today, we've managed to go through some of our aims. And I look forward to hearing from all of you regarding what your situation is and what are the types of things that you think might be a hindrance to reducing the burden of care.
Lovely. Thank you, Dr. Chloe. Fantastic. You've given us a good overview of some key topics. Lots to discuss there, whether we have an orthodontist on our team right now in certain contexts, or whether we're hoping to have one in the future. And I think there's been lots to start off with. So we're grateful for that. So as always, we'll give you a second to think about your questions, your comments. We can talk philosophically about the burden of care, which Dr. Chloe has mentioned is not just an orthodontic only issue, definitely is something that I think applies to everybody on this call. And then also jump into some of the specifics around the kinds of strategies that Dr. Chloe's team has put into place in order to minimize that burden of care, and some of the specific questions you might have about that. So we'll jump right in. If you have a question, please feel free to raise your hand. You can type it into the chat. And again, we have Spanish interpretation, so you can feel free to ask in Spanish as well. If you came late, on the bottom corner, bottom of your screen, likely at least, depending on how your Zoom is set up, you can select the translation. And if you select English, that means automatically you will hear someone's question in Spanish in English. So we are well equipped from our team, Eva and Benjamin from Chile. Dr. Nicolas, good to see you. Please, your hand is up first. You get the first question. Go ahead.
Hello, and thank you very much, Hugh and Chloe, for your excellent presentation. I am here in Chile in an innovation congress with SmileTrain, presenting about ortho in low middle income countries. So in our preparing this presentation and seeing your presentation, my first thought is, in low middle income countries, it's really hard to provide ortho. It's one of the main and most complex treatments in comprehensive care in terms of building capacity. So my concern as a craniofacial surgeon is how we can reduce the need and the burden of the ortho, not from a intervention perspective, more from a preventive perspective. What are your thoughts in that? Like, how can we prevent and reduce the needs of ortho amongst cleft lip and palate patients?
I mean, it's very difficult because things are variable, and I don't think anyone has a single answer. In terms of what I think makes outcomes a little bit more predictable for people and reducing the need for intervention, it tends to be things like avoiding impacted teeth. How do you do that? Really more through monitoring, appropriate staging of bone grafting. And sometimes it also means a sacrifice of some of those really small laterals that are at the site of the cleft. I think I have spent sometimes years trying to bring down both laterals and canines stuck in the cleft because we've absolutely wanted to lose nothing. So I think sometimes if you don't have access to orthodontics, you have to think, how can I make sure that nature fixes most of it on its own? And that sometimes means in terms of timing, more than anything.
Thank you. Thank you very much.
Grace, thank you, Dr. Nico. Grace, please go ahead.
Hi, I just had a question similar to Dr. Nico's question. In the timeline, you talked a little bit about relapse for older patients. and how can you reduce relapse, and what are common relapses that adult patients have? Because that to me is a really important area. And if we can reduce any sort of relapse, what would that look like?
I think relapse can come from different places. Part of it sometimes is the treatment plan that we've made. You know, sometimes just particularly I'm thinking orthognathic relapse. You know, if we've overcooked an advancement and there's been a bit of relapse in the maxilla, which is why I think a lot of the teams I work with tend to go with biomaxillary osteotomies, which carry an increased risk, but that's their way of mitigating that. I think whether you're a cleft patient or not, retention is of utmost importance. I'd say the main problem that I face is we have those retention conversations with patients when they're teenagers, when they finish their orthodontics, and it's not always very easy to get them on board, particularly when they've had treatment for very, very long. I think I had a conversation with a patient this week who I'm retreating in her 30s. She had about 10 years of orthodontics on and off, but she was trying to explain it's a very difficult thing as a teenager to take all of those things on board when you've had so many interventions. And I would love to come up with a solution in terms of how to really make it so clear that it's important after they've had all these interventions to be excellent. I think part of it is letting them know that you're trying to really do your best for them, and trying to minimize some of the intervention. So keeping the treatment short so that they can at least comply with some of the retention strategies.
That's great. Thanks for Dr. Chloe. One thing that really stood out for me, and I've been seeing some chat about it, Dr. Chloe, you mentioned the result of, you know, one of the longer term treatment plans around the jaw, and you know, your comment was, you know, you can see a slight improvement. So the question is, you know, when we're talking about informed consent, I think sometimes there can be the idea that, okay, well, there's a checklist we need to go through. We need to make sure that legally we're good, you know, that they've signed off, said, yeah, but I think you're talking more about that sense of, you know, if parents really are invested in this whole process, they're more likely to follow through, and patients are more likely to follow through. How do you balance, and how do you really establish that kind of trade-off between, you know, what's the likely result in terms of what the parent or patient are looking to see in terms of improvement versus the cost and the amount of time that might be required in order to make this treatment effective?
That's incredibly difficult. I think I end up having fairly upfront conversations with even 12-year-olds and their parents about, if we embark on treatment now, that's fine. We can absolutely do that. But you have to know that as you grow, things might change, and we should be open to the idea that we'll have treatment again. So particularly if we're thinking about those kind of skeletal-based treatments. But I feel that there is no correct option for every single family. Some families will want you to have told them about the option of orthognathic surgery from birth, whereas others don't want to hear about it. And they want you to reassure them that, you know, their child is perfectly normal, perfectly capable, and functions perfectly fine, and doesn't require any of these interventions. I think the more I've gotten to know different families, it's easier to gauge who prefers what. But I don't have a solution for everyone.
Thank you, Dr. Chloe. Professor Tim, please.
Good morning, Chloe. Thank you for a great presentation. I'm in a department of speech language pathology, and one of the aspects of orthodontic treatment that we've been wondering about is speech, right? When you insert your appliances, even in typical speakers, everybody sounds like Daffy Duck afterwards. And that, of course, also does something to the patients, to their, you know, excitement about having that treatment. And in the patients with cleft lip and palate, of course, we may have pre-existing articulation and nasality disorders that potentially could be compounded by that kind of treatment. So what are your thoughts on how to handle, mitigate that?
Obviously, I think the appliances that tend to impact the most are those that cover part of the anterior palate, just in terms of articulation issues. At least my understanding of it. I try to move away a little bit from those types of appliances, and try to delay some of the treatment and move on to fixed. The reality is some patients will be able to accommodate it a little bit better and understand that that's a short-term sacrifice that might need to be taken. And others, maybe the child who gets bullied in school, who's already feeling very self-conscious, will not comply with treatment, will not find it acceptable to have yet another thing that makes them stand out compared to everyone else. So that is something that I think I try and explore some of the options when you have, the capacity to do that. That's wonderful. I know not everyone can do that, but usually I will have different treatment options explained to the patient and try and gauge some of the impact that those options will have. And we have a discussion before treatment starts, so that I can gauge what their particular worries are, because some people will just outright refuse anything that covers their palate.
Dr. Chloe, thank you, Dr. Tim. What is your connection to speech therapy? Do you have a team? Are there regular ways of collaborating and talking about some of these challenges where one element of comprehensive cleft care may impact the ability of the other professionals to move forward? What's your learning about this?
Yes, we have a team. So as a team, the whole team would review the patient at different time intervals. But a lot of the time at the stage that I'm seeing my patients, speech is the other kind of specialty that will see them a lot, as well as other aspects of dentistry. And particularly when they're having a lot of speech therapy in school, it sometimes becomes a bit of a balance as to how to progress in that way versus how much you have to wear your appliance. But I really rely on the parents kind of letting me know how their child is getting on so that we can both adapt some of our techniques. But I think speech therapists, even non-cleft specialists, are usually very aware of the effect of the appliances that I put in, so they're usually quite understanding.
Thanks, Dr. Chloe. A quick technical question, and then we'll get to Dr. Siddique in a second. There's a comment on the chat about lingual traps. Can you say anything about that? Is that something you're familiar with?
Lingual traps. I'm not sure that's.
And it could be a Spanish translation thing. I'm not sure. I'm not familiar.
Could be cribs. The little spikes to prevent tongue thrust.
Thanks, Tim.
Okay. No, I have to say that obviously coming from, we're all very institutionalized, coming from background in the UK, I think there is no real emphasis on orthodontics to be able to improve speech outcomes. I know that it's probably more commonplace in other countries where maybe you might think about intraoral appliances to help in speech therapy. That is not something that we do or something that's been asked of me in the past, but I'm open to hearing about other teams that might have.
Very good. Thank you. Dr. Siddique.
Thank you very much, Dr. Mr. Hoog, and thank you, Dr. Roland. Thank you very much for your presentation. My question, did you use distraction osteogenesis in your treatment? Distraction osteogenesis?
Distraction osteogenesis?
Did you use the distraction osteogenesis with your treatment in orthodontics? Yes.
I'd say we would tend to use it at the orthognathic stage, so at the end of growth for the really severe cases. Yes, we do sometimes use it. Probably not as commonplace. We'd use kind of conventional orthognathic surgery methods more commonly.
Thank you, Dr. Siddique. Thank you, Chloe. So one of the questions that I had along the way, as we looked at some of the research that Dr. Chloe presented from the literature in Brazil and elsewhere, was just, the sheer number of visits required to complete an orthodontic plan, or at least attempt to complete, 60 plus. My question for the group is, in your team, do you have access to that data? If you wanted to do a bit of an analysis in your own team about the number of visits that's required, whether it's for speech therapy or for orthodontics, is that something that you have access to? And is that something that your team uses? And I'll read Dr. Yuri's in a second. Chloe, I'd like to, while the group thinks about it, what stood out for you? Is that literature how did it strike you, and what kinds of implications do you feel like when you look at that raw data or now analyzed data, I guess, of 60 plus treatments or appointments required with potentially 600 something kilometers in a high income country?
Unfortunately, not surprising. But I think that what we need to harness a little bit more is, I think someone's mentioned that in the comments. I think part of what we're trying to do as orthodontists is really monitor and only really pounce or intervene at the best possible time. Otherwise, we're pulling children out of school incessantly. Because 10 years, I think, at least for me, I can't imagine spending 10 years in braces, even as an orthodontist, and I'm very keen on braces. It's I can't imagine how disruptive that is to a child.
Thank you. From Nigeria, Dr. Adeola, please.
Yes, thank you. Thank you, Dr. Clay, for the presentation. Lovely. It's something I'd always wanted to attend. To your question, Hugh. Hi, Hugh.
Hi.
To your question, do we have access to such data? Yes, we do in the centers that I'm associated with, because we have what we call clinic attendance records. And looking at this presentation, it will be interesting, really, if we now go back and see how our own findings would be like. It is, the orthodontics is a bit young in our center. It's just like from 2019 or so. So only a few patients of us are completing the orthodontic treatment. But yes, we do have access, and it's encouraging to check now and see with those who have completed. Thank you.
That's helpful. Thank you. Especially with a young profession, that's just a few years of experience so far, but the fact that you have data and that you have some protocols to be able to review it, I think will be helpful when we recognize that, that this is the burden of orthodontics is financial for whoever's funding it, whether the government or an NGO, but also, as Dr. Chloe's been talking about, for the parents themselves in terms of missed opportunities for other things.
Yeah, and I think I'd encourage all of you really to start looking at where orthodontics is undertaken, the impact that orthodontics is having on your patients. So similar types of projects, but also to look at some of the outcomes centered on patients. So how happy patients are at the end, because that's ultimately, no matter how well aligned the teeth are, that's what we're all aiming to do.
Thank you. So Dr. Yuri, Professor Yuri from Bulgaria is in the process of advocating for orthodontics in terms of how it is a requirement for bone grafting, and talking about whether the government acknowledges this as an essential service along the side of surgery. And I don't know if you want to comment any more about that, about making the case, for the importance of orthodontics within a cleft treatment, especially in a situation in middle-income country or upper-middle-income country where, the government could provide more support than it currently is for that kind of comprehensive cleft care.
Yes, I think it's very important. I'd say probably the first step when you don't have access to all of that is maybe concentrating on the phases that are truly essential. And that's where I think, unfortunately, even in high-income countries as the UK, it's becoming more and more difficult to provide every stage of care in a timely manner for everyone. And that's why I think some centres are then reducing some of those cherry on top interventions and reducing it to only those that are absolutely necessary, which is why for bone grafting, it's not done for every single patient. But I think harnessing some of the literature and some of the publications that there are is probably helpful in terms of convincing the government that those things are very useful.
Thank you. So Dr. Chloe, we know that you've recently been traveling, connected with Cleft Charity UK. What are some things that really stood out for you as you collaborated with patients? Just tell us briefly, some of the major things as a professional working in a high income country that stood out for you in terms of the challenges or the opportunities that your colleagues are facing in a different environment.
I'd say, so the colleague who I was visiting there, Dr. Mahfouz in Dhaka in Bangladesh, I think was incredibly multi-talented, makes his own appliances, and I think is technician, orthodontist, dentist altogether. And it was just incredible to see how much of a problem solver he was in terms of not having access to exactly the types of things that we were discussing in terms of the right screws, the right materials, but all through kind of ingenuity of design would just try and problem solve and achieve the same result. I think what was incredible from the patient's point of view, that I wish sometimes happened with my patients, is that they were incredibly compliant, or they seem to be, with every intervention, even the most kind of difficult ones, such as skeletal modification. So those are the things I think that really stood out to me.
Thank you. And again, please feel free to post in the chat or let us know. I mean, if you are in a country like Nigeria, Ethiopia, others that have, you know, somewhat recently been expanding into orthodontic care, what are some of the things that you've determined in your team that are essential, and what are some of the impacts that you've seen now that you're adding that into the suite of support that you're offering to families? Dr. Nico, back to you.
Thank you, Hugh. Well, we work in Southeast Mexico, where we have it's a very low income setting. We started in 2019 with a comprehensive cleft care center, and we started orthodontics 2 years ago. So far, we have entered more than 60 patients in the orthodontic program. The view from the field is that everything that we can do to the patients in these settings do not actually have a main concern of ortho. Like when you look at their main concern is functional in terms of speech. That's their main concern. Late patients, I mean, teenagers and young adults, it's overall healthcare. They have terribly dental decay, and that's one of their main concerns because they have pain and like dental related deformity. So my question in this setting has been more, okay, let's now focus on how to bring braces and high-tech stuff, but let's bring prevention, nutritionist, let's bring overall healthcare, conservative dentistry. That's the main focus, because they don't, I mean, someone working on the fields, they don't need braces, you know? So when I look into a preventive, how to prevent ortho, we're making modifications of our surgical protocols. Like instead of operating the cleft lip at 3 or 6 months, we're operating the cleft lip at 1 year. So we can promote facial growth. And within that time, we're focusing on dental education, so these patients don't get into dental decay. And the palate repair, we're performing like minimal invasive surgery at around 18 months. So basically, that is the thing. I think from a European, US, first world perspective, it's ortho, it's patients need ortho. In these countries, it's how to make it the best for most of patients. When you go to ortho and you can make ortho, it's how to make it feasible for someone that is going to be compliant with the treatment. So you make an investment and make it last. So I think, again, education and oral health education and promotion and disease prevention is the key.
Thank you,
Yeah,
Dr. Nico.
I completely agree here, actually. And, you know, I don't actually put braces on or have orthodontic intervention for every patient, but part of the role of the orthodontist is really looking at development of the dentition of the face. And, you know, sometimes some of the only treatment I might do could just be, you know, suggesting extractions and allowing things to drift naturally, should there be an absolute need for something to happen. But even in terms of prevention, not having early loss of some of those baby teeth means that overall the adult dentition will tend to develop in a better position with fewer chances of ectopia or impaction. So I completely agree that the focus on some patients shouldn't necessarily be braces, but the orthodontist should still have a role partly in prevention and monitoring, and then preventing the need for kind of more complex orthodontics.
Thank you, Dr. Chloe. Thank you, Dr. Nico. Yeah, lots for us to think about here. In terms of when we think of what is the gold standard, I think that I've seen that also, Dr. Nico, where the idea is, oh, well, it must be a full this way, but I think Dr. Chloe is pointing us to look critically at those assumptions and try to figure out, how do we work with patients to figure out and parents to figure out what is the ideal within the resources that we have, which are not infinite. I'll see Dr. Ikenna, and then Carmen, we'll hear you next.
Well, thanks you, and then thanks Chloe for the presentation. Here in Nigeria, my center is Lagos University Hospital, and my experience is that we've been providing orthodontic care for the past. We've had a Smile Train grant for orthodontic care for the past 6 years, and then listening to Chloe talking about the balance of care. Burden of care. We do a lot of pre-surgical implant orthopedics, and we find out that, the literature says, the benefits of the NAMA plans for nasolabial aesthetics and the psychological, confidence that it gives to parents. And we've seen that in our center. So listening to Chloe's presentation, you want to strike a balance between doing something that will significantly benefit the child. Our surgeons also are very happy to see us have that. They are happy with what we do with PSIU treatment in terms of, improving, making the surgical procedure, quote and unquote, easier for them. In severe bilateral cases where we're able to align the premaxillary segment with like a NAMA plan. So I think for me, it's a lot of, I think for our team to be a lot of reflection in terms of saying, okay, I'll call ourselves a low resource setting, and we're able to, it will be good to look back and see that while the parents are happy when we do something for the children at the early stages just before surgery, as against not having anything done for them. That's in this environment. So you look at the reasons for which we carry out, I'm using PSI as an example, and then I'm listening to Chloe. You want to look back and make sure that while you provide value, you're also looking at the burden on the patient themselves and making sure that the burden doesn't outweigh the value that you provide. So Chloe has raised questions that we will go back and look at. And because when you talk about patient-centered care, their patient is happy, and at what cost is that value outweighing the cost because they have to come in every week, or do we place that in our own evaluation for choosing patients? So I think the presentation is a good one because we tend to, my center does almost every aspect of care apart from probably orthodontic surgery. So, and we have quite a number of visits. So it's looking at the burden of care is not something that we have looked at. So this is really good.
Thank you, Dr. Ikenna. Lovely. Great to hear a snapshot of Nigeria. Dr. Chloe, quickly, I know we have a couple more comments and we have to wrap it up a little bit, but this is, we're off to a good start here. Please go ahead. Dr. Chloe, any comments in response to Dr. Ikenna?
Yes, but I think it's, it's really encouraging that there's such good feedback from that intervention from parents. I think it's just then looking overall at when that cohort who's been prepared presents against orthodontic treatment compared to a cohort that doesn't. What has changed? What are the differences? And how are we still going to be inputting the same amount of care at that stage? Although, those kind of pre-surgical stages are not just for us as orthodontists, they're also thinking about the surgeons, we're also thinking about the parents. So it's a really complicated balance, but what works in one unit might work differently somewhere else.
Thank you. Professor Pamplona.
Hi, good morning from Mexico. So I was thinking in what Nico was saying, and of course, I agree with Nico and with Yuri that education is very important and be clear with families about what they will need and the consequences. But something touched me about the doing a little bit late the surgery, especially the palate surgery, because we know that will cause more speech problems, and that will be a problem also for them and for families. So just to comment, so difficult to get into the middle and perfect point of the multidisciplinary treatment, right?
Thank you. Yes, I think we talked a little bit about how all this fits into the big picture. We're not all orthodontists or surgeons here, but we all can see how these different treatments we're talking about have an impact on one another. And there are costs and benefits, which I think Dr. Ikenna was pushing us to also. How do we take data and reflect critically, in our teams about what the impact of what we're offering and how it could be improved, especially, when some of these services in a comprehensive approach are pretty new, are in the nascent phase still. Michael, please.
Good morning. Chloe, thank you so much for a wonderful presentation. You mentioned drifting. How successful is that in low, middle-income countries over time?
I think in my experience, drifting is particularly successful when the right kind of stage of eruption of the teeth that you want to drift is targeted. That obviously relies on radiographs, or at least kind of knowing the stage of dental development. But drifting is going to be much less successful, let's say, in an adult than it would be in a child where there's still growth potential. So a lot of it is case selection.
Okay. Thank you
Wait,
so much.
Sorry, I posted in the chat, but just quickly, for the rest of us, could you just briefly outline what you mean by drifting?
Oh, drifting is just really letting teeth passively erupt and move into a better position. So sometimes people will call it driftodontics rather than orthodontics. As a way of improving positions of teeth without necessarily applying a force. Okay, interesting. So it's a lower intensity sort of approach, less proactive, I guess. It might involve removing some baby teeth or some adult teeth or any obstruction in that particular area and allowing the teeth to normalize in that area. Great. And of course, we somehow managed to get through this whole conversation without talking about your contention around NAM and why. We don't have time to jump into the whole piece, but Zainal has posted just a quick question. How widely used in the UK would you say right now NAM is as part of a comprehensive cleft treatment approach? It isn't. There are centres in London that are trying to reintroduce it. I think it works better in units where parents are very close to the unit and probably where the unit is also better funded. Because it requires quite a few visits. I think there's a lot of interest in it. Other units will tend to use kind of off-the-shelf type things, such as Dana-Cleft, to prepare parents and patients for surgery, but it's not very widely used. Thank you. Thank you. Lovely. All right. Well, our time is there. We could talk for a lot longer. Thank you for everyone who jumped in on the chat or with questions, Dr. Chloe. We've really benefited from your thoughtful approach, your clear slides, and I think your reasoned, sort of using data to help inform how we make the best case. And I think there's lots more to discuss around burden of care. Niti, my colleague, I think has another slide for us to show, and then we're keen to hear from our colleague Grace in New York. The thought for us is, what is an idea that's most compelling for you? How will you apply this in your own context? Is there somebody you should share this link with in talking like Dr. Akena did about how we can think more clearly about the circle of care or the burden of care, pardon me, in your teams? What's some of your next steps? So that's the challenge for you. And in continuing with this focus on orthodontics, my colleague Grace in New York from SmileTrain, please tell us a little bit about a resource that you've been working on.
Thanks, Hugh. Hi, everyone. My name is Grace, and I'm thrilled to share these two resources, educational resources on digital alternatives in cleft treatment. These were developed in partnership with FDI, and on the left side of the screen, you'll see a QR code that links you to the Massive Open Online Course, or MOOCs. That was just launched last month. It's a 4.5-hour course that's open to everyone. And this course covers the evolution of cleft care, the benefits of digitalization in comprehensive cleft care, and the role that digitalization will play in the future of dentistry. And then on the right side, we have a QR code that links to an interactive tool that was created to help dental professionals navigate through the different stages of care and digital alternatives. Again, these are free and accessible to everyone and everyone. Digitalization is evolving very fast, and it's important that we familiarize ourselves and learn because it will help to standardize quality of treatment and make care more accessible to patients. So feel free to take a screenshot or a photo of this slide. And if you have any questions, I will put my email in the chat. But thank you so much.
Fantastic. Free resources, and a huge thanks to one of our founding sponsors for the Circle of Cleft Professionals, SmileTrain, in pushing forward on all of these elements of comprehensive cleft care. Thank you very much, Grace. Well, our appointed hour is finished. You can see Grace's email there if you'd like to get further in touch. If you missed that QR code, it will be on the recording that will go live on YouTube a little bit later this week. We're delighted to have had Dr. Chloe Rowland from the UK join us. Thank you for your really lovely overview of some of the things you've been wrestling with in your own practice, and that idea of how we can apply it in low and middle income countries, and thinking through, how to make the care as effective, as efficient, and as patient-centered as possible going forward. So we're delighted to have everyone join us. Thank you so much, and we hope you have a great evening, afternoon, or rest of your morning. Bye, everybody.
Bye, everyone. Thank you so much.